Hello friends, I am Dr. Harsh Mathur from Om Netralay, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. It's not meant for children. And in this case, we will be discussing about how to manage an intumescent cataract, how to go about doing a minirhexis, and tilt the dense endonucleus and then chop it supracapsularly. So this is a dense intumescent white cataract with a high intralenticular pressure. So the chances of a runout rhexis and an Argentinian flag sign are high. So going about the regular capsulorhexis doesn't work all the time in this case. So I find creating a minirhexis, reducing the intralenticular pressure, and then making an adequate size rhexis is a good option. So this is a 62-year-old gentleman having an intumescent cataract in both the eyes. And so far the capsule has been stained nicely to improve visibility. Now with 1.4% sodium hyaluronate, chamber is made tight and a nick is made in the capsule and create a C-flap. This curved C-flap prevents the extension of the capsule. Still you can see it's trying to run out. So now I am creating a small rhexis. This small rhexis will give me access to the loose cortex, which I can then easily remove. So this is though an oval rhexis, but doesn't matter. Now is the time to remove all the cortex, and you will see there was so much of liquefied cortex. With the help of a Simcoe cannula, so I find this Simcoe cannula a great help in removing all the cortex. We can rotate the nucleus with the help of this Simcoe cannula and eventually get most of the cortex out, and thus reducing the intralenticular pressure. So now the capsule behaves like a normal routine capsule and the adequate size rhexis can be easily made. So now with the help of a Utrata, we are attempting for a 5.5 mm of rhexis, and we have got a adequate size rhexis, approximately 5.5 mm. So now we have dealt with the first difficulty. The second challenge is to chop and emulsify this dense mobile nucleus. So if we try to sculpt or chop it in the bag, then it is stressful to the zonules. So let's tilt and tumble it out of the bag. Now this one pole is out of the bag. Let's see how this goes about. So once you tumble this dense nucleus out of the bag, it's easier to go behind the nucleus with a chopper and chop it into 2 halves. So I have held it at the center, and then that's it. We've got 2 heminuclei, and these can be sub-chopped and easily emulsified. So I am trying to be as close to the plane of the iris as possible, and these 2 sentinel air bubbles giving me a good idea that I am away from the endothelium. And now is the time to deal with the second heminuclei, sub-chop, and we are able to manage this dense nuclei in no time. So this tilt and tumble can be a good way to manage this dense nuclei, keeping the posterior capsule and the zonules safe. And as most of the cortex is liquefied and comes out, the central core dense nucleus isn't that large, so it can be easily dialed out of the bag from a 5.5 mm of rhexis. Not much of cortex is left, and we are able to clean it in no time. And now is the time to inject the IOL. So by the wound assisted delivery, a hydrophobic intraocular lens is injected. The leading haptic goes in the bag, and the trailing haptic is dialed in. We've used a lot of OVD. Going behind the IOL is a good idea. Clean up all the OVD from the anterior chamber, from behind the IOL, to prevent intraocular spike post-operative day. So the take-home message is, in these intumescent cataracts where the intralenticular pressure is high, I would recommend to do a minirhexis first, reduce the intralenticular pressure, and then increase the size of the rhexis. And if the endonucleus is small, then we can always tumble it out of the capsular bag, and chopping this free mobile dense nucleus becomes easy once you are able to go behind the IOL with the chopper. I hope you like this video. Do it next time. And that's it. The case is done. Thanks for watching.